This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Welcome to Fellows Conference being given today by Matthew Gold, who is one of our academic clinical investigator pathway fellows. He comes to us from University of Chicago. And today he is going to be talking about phenocopies of HCM. Take it away, Matthew.
Thanks, Dr. Cooley. Good morning, everyone. Thanks so much for joining us this morning. Uh, like Dr. Cooley said, I'm a first-year clinical fellow, and I remember my second month of clinical fellowship, I got really, really excited when an echo came my way, and it said, oh, HCM, and, you know, very green Matthew got very excited, and then he opened up the first echo image and was quite disappointed. And I was reminded back to the time when I was in residency in med school when you always think it's lupus, a pheochromocytoma, and now I'm thinking, well, I'm going to lump HCM in with that group because it almost never is truly HCM. So today we're going to talk about a very interesting case about a young woman with an HCM phenocopy. So part of this is that we're going to want to understand some of the behavioral and cognitive biases in medicine and show that these can actually really significantly affect our decision-making capacity and our diagnosis making. We're going to review the diagnostic criteria and some of the typical findings for sarcomeric HCM, which is our classic HCM. And then we're going to compare some key differences between some of the HCM phenocopies. So I'll warn you, we're going to start with a couple board questions, and these are real questions that I have come across in some of my readings. And I'm going to warn you that these are fairly difficult, actually. So the first one, and we'll go over the answers at the end, but this is kind of a primer. The first question is: a resident is nearing the end of their shifts, is looking forward to a nice long nap. A patient is complaining of chest pain as their final patient of the day. The resident took care of 3 other patients earlier in that day with complaints of chest pain and was all determined to be benign causes. And the resident is quick to assume that this patient must too also have a benign cause for their pain. And this resident's assumption is what type of bias? Is it an availability bias, confirmation bias, omission bias, or visual bias? The second question here. 22-year-old man presents with left ventricular maximal wall thickness of 14 millimeters and this following ECG. Which diagnosis would you be most likely to consider? Let's get started with the case. So we have a 54-year-old woman with long-standing hypertension and diabetes, and she presents to established care in HCM clinic. Earlier this year, so at 54, she was diagnosed with apical variant HCM via a cardiac MRI that was done at an outside hospital. Notably, she comes with her 2 children and her husband, and her children are adults and healthy. And she denies any family history of HCM, unexplained sudden cardiac death, or unexplained death at a young age. So very early on, red flags should be going off for this diagnosis of HCM. And so we come to this outside hospital cardiac MRI read, and you're only really able to get this in care everywhere. And what this shows is that you have a significant LV wall thickness of 1.7 centimeters and a mid-cavitary gradient of 80 millimeters of mercury. So that's quite obstructive. You see a hyperdynamic LV systolic function. You see that the LV cavity is small. And you're seeing that there's this mid-myocardial delayed hyperenhancements in multiple areas in a non-ischemic pattern. And they say in the radiology report, of course, they're going to hedge their bets a little bit. This is concerning for possible apical variants of HCM, and they recommend genetic testing. So I want to kind of tell us, we aren't as good as we think we are in diagnosing pretty much anything. And we know in certain studies that diagnostic failure rates can be as high as 10 to 15%. But we want to make sure that we understand all of our cognitive and behavioral biases because this can have a significant factor. There was one review that I'm not going to go into detail about, but it did show that cognitive bias contributes to diagnostic errors in a very high proportion of specific case scenarios, 36 to 77%. And I found this really great figure, essential illustration published in JACC, Basic Science. about basic and translational science, and it kind of shows you how there's two main approaches that you can come to when you're thinking about a decision making. The first on the left is this guy with sunglasses on, and it's this biased approach. And I typically think about this when I'm getting woken up at 3 in the morning for somebody with chest pain, and I'm thinking quickly. I'm not necessarily taking an unbiased approach, and a lot of these biased approaches come from pattern recognition and in our past, and it's intuitive, fast, and sometimes it can be irrational. Compare that to an unbiased approach, which is analytical, slow, and rational. And this requires us to be aware of our cognitive biases. And in addition to just being aware of that, have some bias mitigation. There are a variety of different tools that this article does talk about, and we'll go into just a couple of them a little bit later. There are a lot of different cognitive biases in medicine, and if you look into the literature, you can find dozens of different ones. A lot of them are fairly straightforward, but what I do want to talk about is the big difference between anchoring bias and confirmation bias. Now, anchoring bias is similar to confirmation bias, and it refers to the practice of prioritizing information and data that supports one's initial impressions of evidence, even when those impressions are incorrect. So you can imagine just kind of attributing someone's back pain to known osteoporosis without really ruling out other potential causes. Compare that to confirmation bias, which involves selectively gathering and interpreting evidence to conform with one's beliefs, as well as neglecting evidence that contradicts them. So example of this is kind of refusing to consider alternative diagnosis once an initial diagnosis has been established, even though other data might contradict it. So anchoring bias is a cognitive bias that causes us to rely heavily on the first piece of information we're given about a topic. And there was a really great study, this was published in JAMA Internal Medicine, that kind of was trying to identify, do we have any objective evidence to show that anchoring bias affects decision-making processes? But the objective of this was to examine whether physicians were less likely to test patients for heart failure for PE. So all these patients with heart failure come into the ED, and we're trying to see, based off of bias, are they going to be tested for PE? This was cross-sectional, was at the VA. And basically, patients were either, physicians were either exposed to seeing a CHF diagnosis in the triage visit or not. And then here we were just looking to see if the main outcomes were testing for PE in a variety of different ways. So these are the results. A lot of patients in this, only 2.5% female, and they all have heart failure presenting with shortness of breath. 4% of them had mention of CHF in the visit. So remember, 4% were in one group and 96% were in the other. So a little bit, I mean, it was quite mismatched. Overall, only 13% received PE testing, and only about 1% were ultimately diagnosed with a PE. Now, the really interesting part was that in adjusted analysis, mention of CHF just in the triage notes was associated with a 4.6 percentage point reduction in PE testing and a much longer delay to actually get PE testing. So this is a really great way. I mean, we see these triage notes all the time, and we don't necessarily think that this is affecting our decision making, but this study really nicely shows that in terms of ED providers, at least, that triage note really does affect our bias. Let's transition a little bit to just what normal sarcomeric hypertrophic cardiomyopathy is and how it will typically present before we get into some of these phenocopies. So HCM is very highly prevalent now, and we're noticing that more and more folks are getting diagnosed with this. It's autosomal dominant inheritance. It's the most common cardiac genetic disease, and we think that between 1 in 200 to 1 in 500 people have this disease, and it's diagnosed with a wall thickness of greater than 1.5 centimeters or 1.3 centimeters in patients with family history, and an absence of other diseases causing LVH. And that really is just the biggest key in diagnosing HCM. And a question I commonly get is how many patients actually have a sarcomeric gene variant? And only about half of these patients with HCM will have a positive genetic test. Shown on the right are the different types of variants that you have for sarcomeric HCM, and you can see that the myofilament gene positivity rates vary quite differently. The majority of HCM that we're familiar with is this sigmoidal HCM, where you can see that the septum is asymmetrically hypertrophied compared to the rest of the LV, even though it may also be hypertrophied. Sometimes we get this reverse curve HCM, which is another form that we're also quite familiar with, and you can see how this LVOT is really quite significantly obstructed. You can also have apical HCM, which is kind of more apical sarcomeric hypertrophy, as you can imagine, than just this neutral HCM, which is only about 10%. And folks with HCM have a really high disease burden. People will progress, about 10 to 20% of people with HCM will progress, and about 5% will develop end-stage heart failure. 30% of these patients have atrial fibrillation. However, if they're diagnosed before the age of 40, about 50% will go on to develop advanced heart failure, and 60% will have atrial fibrillation by the age of 60. And this graph and this figure on the right really shows nicely, this was published by Marin in Lancet, really showing that in folks who are untreated with HCM, they're going to have much higher related mortality. But if we can treat these patients with guideline-directed medical therapy, ICD interventions, septal myectomies, heart transplant, their mortality rates drop precipitously. Coming back to our patient, this is just some objective findings, and things I really want to point out here is that she's quite hypertensive, 177/67, and notably, she's actually on quite a few antihypertensive medications. You can tell that she has a little bit of a systolic murmur, just kind of trace edema. Very notably, her genetic testing was negative, and I think that's kind of one of the biggest takeaways here. Even though about 50% of folks with HCM will be genetically negative, this still tells us we have a little bit more work to do. I'd be remiss if I gave an HCM talk and didn't at least briefly talk about the guidelines for diagnosis. So this is taken from the most recent updated guidelines published in 2024. And I'm not going to go in through all the nuances of this. I think a lot of us already know this. But there's a lot of the things I do want to show is that there's a lot of class 1 indications here. And this is a really popular testing question. Same here with gene testing. Basically, you're going to want to remember that we do cascade testing in folks with positive genotypic variants, and these are going to be in likely pathologic or pathologic variants, or even so if someone's getting reclassified with a variant of unknown significance or likely benign or benign, we're still going to want to do clinical surveillance in their family. So regardless, you're going to be doing some sort of testing in folks with anyone with an index case. Let's talk about, so HCM is a complex diagnosis and requires a lot of different data points. And EKG is actually one of the hallmarks that we use in actually diagnosing HCM. So this is a classic HCM EKG that's taken from a real patient, and it's showing, and there are a few key findings in a classic HCM EKG, and one of these is going to be LVH, as you can imagine, but then also almost pathologic Q waves. You're going to see these kind of deep, narrow, almost inferior in the inferior leads and in some of the lateral leads as well. And I think this is a really good example. These definitely catch your eye, but these look quite narrow, usually less than 40 milliseconds. You also typically have left atrial enlargements, get ST segment depression and T wave inversion, which this EKG doesn't necessarily really have. Left axis deviation, and then also it's often with atrial arrhythmia. So if you're seeing someone with an EKG that looks kind of similar to this with AFib or WPW, you might be wanting to think about HCM. Now for apical HCM, it's quite different. The EKG can look quite different. You can imagine with the really hypertrophied apex, you're going to get EKG changes. And classically, you'll find that you'll have LVH with these giant T wave inversions in the precordial leads. Now, what I will say is if you look into the literature about apical HCM, it seems to have a higher prevalence in Japan. And so if you're having a patient of Japanese descent with an EKG like this, you might want to be thinking about apical HCM. So these pictures are what the LVOT Doppler looks like in an LVOT obstruction caused by patients with HCM. So panel A is continuous waveform on a resting LVOT, and the pressure gradients is about 19, and you can see it's a fairly symmetric looking triangular pattern. Panel B is when the patient Valsalvas, and you can see the triangle is turned a little bit almost into a dagger-like shape. But if we turn the probe just slightly, and that's what panels C and D are showing us here, if we just turn the probe a little bit slightly, it really kind of reveals these more dagger-shaped Dopplers. And this figure is a really nice figure that kind of tells us a little bit why we have this dagger-shaped pattern. So kind of orienting us a little bit, this is a CW Doppler, and this kind of lighter bluish gray here kind of shows this very symmetric looking Doppler waveform, and that's going to be a non-HOCM waveform. And then you can kind of see it kind of becomes more of a dagger shaped. And what that actually is showing us is the concurrence MR. And it's really thought to be this concurrence MR is competing with the forward flow in an asymmetric pattern. And so then you can kind of see that we have this residual LVOT obstruction. So let's go back to our patient, and I really just want to show you, this is what her EKG looks like. And to me, it's pretty unremarkable. You know, if I kind of really want to squint, I can be like, oh, maybe these ST segment changes are a little different, but I'm not really seeing any LVH. I'm not seeing any type of arrhythmia. Maybe going like a little bit fast, but overall, this was read as normal sinus rhythm. So immediately I'm thinking, okay, especially for an apical variant HCM, when we would expect to see really significant ST segment changes, we're really just not seeing that here. Let's look at her echo. Not the best quality here. But I think just overall broad strokes, what you can see is that the LV size doesn't look particularly that small. We are seeing hypertrophy, but I feel like in the posterior wall you're seeing it a lot more, not necessarily in the apical, in the apex as well. And so this doesn't exactly look like a classic HCM. This is the other another view of the echo, and what I want to show is that this ventricle looks big, and you can see that there's it's a fairly large cavity, not necessarily classic for our HCM. And then this is what the Doppler looks like. It's fairly symmetric here, and we're seeing quite a big discordance with how much the pressure gradients of the echo is showing. This one's only showing about 17 millimeters of mercury at rest. So kind of coming back to our case, the patient began a workup for secondary hypertension. And secondary hypertension, we are faced with this a lot actually as cardiologists. And there are some mnemonics that are out there, and some folks might remember CHAPS, which is Cushing syndrome, hyperaldosteronism, aortic coarctation, and pheochromocytoma and stenosis of renal arteries, but this is just insufficient. And you can also add in CHAPS recents, and it's going to have a little bit more a broader differential, which very importantly includes OSA and drugs and just kind of any kind of renal abnormalities. And so I kind of like this mnemonic a little bit better, even though I think that it's still lacking. So the patient ends up undergoing a CT abdomen. And this is this is a screen grab from the PET scan. And what's really interesting is that we have a mass in the retroperitoneum. This ends up being a paraganglioma. So when we think about HCM phenocopies, there's quite a few, there's a very broad differential, and we can think of infiltrative diseases, amyloid, different storage diseases, Fabry disease, glycogen storage disease. You can see there are quite a lot of possibilities here that you can have for an HCM phenocopy. We'll talk about some of these, but one of the things, you go in and you try to take a look at what the differential is for some of these phenocopies, but what I really want to stress is the biggest one is just hypertensive heart disease. Very briefly about a paraganglioma, because that's what this patient ended up having, which presented as quite obstructive LVH. It's very rare. It's kind of known as this extra-adrenal pheochromocytoma, and a lot of them, most of them, the vast majority of them, secrete norepinephrine and are sympathetic in nature. And they're usually associated with neurofibromatosis type 1, von Hippel-Lindau syndrome, and MEN types 2A and 2B. So when we're trying to differentiate the different types of phenocopies that someone's coming to you with an HCM diagnosis and you think, well, maybe this isn't. There are a couple different ways that you can frame your differential decision making. One is just the age at presentation. You can kind of separate, if they're neonates or infants, you might be thinking about glycogen storage diseases, mitochondrial diseases. Adolescents or young adults, you're going to get Danon disease and Fabry. But then also you start getting the sarcomeric HCM is when it kind of starts becoming more prevalent and seeing it. Granted, it's going to be, pretty pronounced in these adolescents and young adults. They're not going to have a whole lot of other reasons to have hypertrophy, and so this is when you might be a little bit more confident in your decision making. Keep in mind that in elderly folks, the diagnosis of sarcomeric HCM is just not going to be that common. So if you have somebody who's 60, 70 and getting a new diagnosis of HCM, it's just not going to be that likely. Also pay attention to multisystemic involvements, because that's also going to point away from sarcomeric HCM. You can get some lab tests. This is going to be, renal failure is really going to be seen in just very more pronounced Fabry disease, and elevated CK is going to be much more pronounced in Danon disease, but these usually aren't that subtle and are not going to necessarily be caused by sarcomeric HCM. EKG findings are also critical. So we really use EKG. There are studies that are ongoing that's trying to use AI for just the diagnosis of HCM, and with very interesting results. But you can think about if there's a short PR interval, almost like a WPW, you're going to think more about Fabry disease or mitochondrial diseases. You can look at the QRS complexes, and if they have, and that can be really helpful for some of these HCM phenocopies. If they have a really small QRS complex, you're going to be thinking more cardiac amyloid. But if they're really big and you see a significant LVH, you're going to be thinking more about a sarcomeric HCM or Pompe or Danon disease. And then especially CMR. I mean, this is fairly critical, but there's a lot of overlap as well. But this is also going to be a really big data points for us when we're trying to make this diagnosis. So let's start with some of these HCM phenocopies. These can each be a lecture in and of themselves. So I'm going to try to go over just some of the key differences between these and how best to identify these diseases if you come across them on your boards. So hypertensive heart disease can be difficult to distinguish, and there's an overlap of about 25% with folks with hypertensive heart disease and both sarcomeric HCM. So we might think that this is fairly straightforward, but it's often not. And you can have SAM, or systolic anterior motion of the mitral valve. One of the key differences with sarcomeric HCM is that usually this occurs later in systole, and that kind of helps show that dagger shape as well. Usually, sarcomeric HCM is going to have worse diastolic function and lower early diastolic velocities and reduced strain. Um, and like I said, reduced strain is usually seen more so in sarcomeric HCM. Glycogen storage diseases is one of the banes of my existence. I feel like I try to remember these all the time, and they always go out of my head right after a board exam. But some of the key findings in these are multi-systemic, and these are going to present at early ages. So if you have someone who's really young with multi-systemic features, start thinking about, and with cardiac manifestations, you might want to start thinking about a glycogen storage disease. Now, they are going to have fairly extreme LVH, and this is usually because of glycogen-filled vacuoles that cause LVH as opposed to a myocyte disarray in a background of fibrosis. And they're going to have early progression to a dilated cardiomyopathy. And you're going to have ventricular pre-excitation in some of these conditions, and it's been hypothesized to be caused by a unique mechanism of disruption of the annulus fibrousness and by the glycogen-filled myocytes. And that's a little histologically distinct from some of the other accessory bypass tracks. There's two that we're going to talk that I'll briefly talk about. The first is Danon disease. This is deficiency in LAMP2. It's X-linked dominant, so you're going to see it much more often and more severely in males. And oftentimes males have pass away before the age of 25. And hypertrophic cardiomyopathy with obstruction is seen in up to 90% of these patients. So, it's Danon disease that's causing this HCM phenocopy. However, they still have quite high obstruction. And the other one that's commonly tested is Pompe disease, and this is an autosomal recessive disorder. It's caused by a abnormality in the acid alpha glucosidase deficiency, and it's multisystem. So just remember, it's multisystem. It's glycogen deposition. It really manifests, early and young, and they often have proximal myopathy in addition to this. Fabry disease is another commonly tested HCM phenocopy. This again is usually not so subtle. They're gonna have it starts in childhood. They have this tingling and prickling and burning sensation in their palms and soles, and they end up having these really significant angiokeratomas on their legs. Like I said, the symptoms often are before the age of 10. They have multiple cardiac abnormalities. Such as, angina due to microvascular ischemia. And you can imagine someone, who's 10 with angina, you might want to be thinking about Fabry disease. These arrhythmias, a short PR interval. And then they're going to have this kind of, they're going to have a more concentric LVH as opposed to asymmetric. And LGE is going to be found mostly in the basal and inferior lateral wall. And these angiokeratomas look quite pronounced and prominent. And I thought that this was a good picture to show that. So again, this isn't necessarily so subtle. Amyloidosis is another one that could, we could talk for hours and hours and hours about amyloid. I'm just going to kind of quickly go through some of this. Major types, you have AL amyloid, which is light chains produced by abnormal plasma cells. You have ATTR amyloid, have this normal or abnormal folding of the TTR protein, kind of the most common, and get also types of AA amyloid. Have low voltage on EKG. You can get some Q waves. And the echo is going to have this kind of classic biatrial enlargements, increased wall thickness with sparkling appearance, diastolic dysfunction, the cherry on top appearance on strain that a lot of us kind of know. Mitochondrial diseases is another one. These can be hard. It's very heterogeneous. They're causing mutations of the maternally inherited mitochondrial genome. Remember that it's our mothers who pass down our mitochondria to us. It can present at any time, but one of the things that the boards like to test is that they most commonly present with delta waves more frequently than any of the other phenocopies. And it can present with all types of cardiac manifestations. You can have non-obstructive HCM, cardiomyopathy, kind of just sometimes get a mild concentric hypertrophy. But a lot of these patients will deteriorate and deteriorate quickly. So trying to come up with a framework for how to better distinguish from the HCM phenocopies. Some folks try to think about, oh, is this a hypertrophic phenotype? Is this a restrictive phenotype? How can I best understand this? And one of the keys that I just want to say is, don't use this. Don't use this. You can see amyloid can present with a hypertrophic phenotype restrictive. HCM can even have a restrictive phenotype as well. Same as these glycogen storage diseases and Fabry disease. It can all be hypertrophic or restrictive phenotype. So when you're trying to come up with a diagnosis, it's not helpful to think of it in these kinds of ways. And you have to think of it really with a well-rounded view. And so this is a really nice slide that I took from a paper that was published a couple of years ago. And it goes into showing some of these. These are, we have sarcomeric HCM, amyloid, Fabry, hypertensive heart disease, and athlete's heart. And on the top panels, we have just typical echo findings. And on the bottom, we have CMR findings. And what we can see is that there's a lot of overlap with a lot of these. And so just kind of coming down to the CMR, usually the native T1 and T2 is going to be elevated for our classic sarcomeric HCM. You're going to have often some LGE. This is going to be frequent. It's usually mid-myocardial and epicardial that we're going to see this LGE. And we can compare that to just hypertensive cardiomyopathy, where we're going to have more of a concentric LVH, but usually a normal T1 and T2. But you can have LGE in hypertensive heart disease. So we have to be careful. Just because we see LGE doesn't necessarily mean that it's not hypertension. Compare that to athlete's heart. You're not necessarily going to have LGE, and that can just be kind of a normal finding. Just very, very briefly about amyloid. The CMR can be a little bit tricky here, but the echo findings are going to be quite different as well. You're going to have that apical sparing on strain. It's more concentric LVH, really high degrees of diastolic dysfunction. The LGE on CMR is usually subendocardial, but you can have some transmural involvements. Fabry disease, I don't think that a lot of us are going to remember the CMR findings of Fabry disease, but you can get some of this overlapping in LGE, and sometimes the T1 and T2 can be normal, sometimes shortened or reduced. But the LGE is typically in the basal, inferior lateral, and mid wall. I guess that's kind of more classic for Fabry disease, and I really didn't know that until I reviewed this. So how can we combat some of our biases that we have that may inhibit coming to an accurate diagnosis? Well, this has been studied before, and there are a lot of different ways that we can try to combat this. And I want to let you know, oh, if you're discouraged by the fact that we're not that good at diagnosing, well, we are right now engaging in bias mitigation strategies. We are doing some specific training. We're having discussions, but a lot of it is kind of about remembering that we do have these biases and being vigilant and trying to remember how best to come to our diagnoses. Kind of coming back to our case, the patient underwent a surgical removal of the paraganglioma. We can see this is her cardiac MR initially. We can see it's she has quite hypertrophied LV myocardium, and it showed a mid-cavitary gradient of 80 millimeters of mercury. But then post-removal, her blood pressure normalized, her catecholamine elevation resolves, and her cardiac symptoms greatly improves. Now, this is her cardiac MRI 1 year post-removal, and we can see that this mostly has resolution of her LVH and her mid-cavitary gradients. Oh, well, I gave away the answer here, but coming back to our first question, with the resident who was nearing the end of their shifts, had been told about 3 patients with benign chest pain, and then kind of quick thoughts that a new patient's coming in with chest pain is going to be benign. This is an example of availability bias. And then in question 2, a patient's a young man with LVH comes in with this EKG, and one of the things that really kind of determines this diagnosis of myocardial disorders, we see these delta waves here. And delta waves are going to be most common in these mitochondrial disorders in patients with the HCM phenocopy. So 2 just, overall big picture conclusions. There are multiple scientific biases that's often overlooked that affect our decision-making process. And studies have shown that these biases really do kind of seep into our quick thinking and can delay our decision-making. And HCM is just not an easy diagnosis. The guidelines, kind of say, oh, just look at the LV wall thickness, but you have to make sure you exclude other causes. So HCM, sarcomeric HCM, sometimes in the absence of genetic testing, can sometimes almost be a diagnosis of exclusion. That's all I have for you today. Thank you very much for your attention, and I'm happy to take questions.
Thanks, Matthew, for the great presentation. I know I've had a couple patients at the VA who, interestingly, the bias has been a little bit more towards amyloid, and it's either been HOCM or something else. So really important to consider those alternative diagnoses. I'll open up the floor now to any questions or comments. And I notice we have some of our HCM experts on the call, so would love to hear from you as well.
Good
Matt,
morning.
Go, Oslam, go.
Oslam here. Matt, congratulations. Fantastic talk. And I'm so glad that you have an interest in this disease field as well. I mean, as you suggested, about 10 to 20% of all patients with LVH actually has HCM, which is not many. We have many other conditions causing LVH. And as you said, one of the most common causes is hypertension. And I think we have to make the distinction because we don't want to treat an amyloid patient with mavacamten or vice versa. We don't want to treat an HCM patient with tafamidis. With the invention of all these novel therapies, we really have to make a distinction. We really have to be careful in terms of making an accurate diagnosis, which is not easy, as you said. When I joined practice in 2009, I thought I was going to see a bunch of HCM patients, and I was really excited. Just a couple of months later, I realized that my main job was to diagnose patients with other diseases like hypertensive heart disease or Fabry's or amyloidosis. And only about probably 1 in 5 patients ended up having true HCM. So the diagnosis is very challenging. It's not straightforward because there's no gold standard testing that we use to diagnose HCM. And I kind of go through, a bunch of things with the patient. So I use 4 different parameters to come to a diagnosis eventually. We use diagnostic imaging, EKG, echo, MRI, and they all have nuances. And as you said, about 5% of patients with HCM with significant LVH has a very normal looking EKG. And that's typically from, having confined, very focal hypertrophy, not having enough fibrotic tissue and things like that. So you could have a normal looking EKG. MRI has significant nuances. I mean, you mentioned the definition of HCM needs to meet an LV wall thickness of 1.5, and it could be less than that if you have a significant family history. And I'll tell you that, especially with patients with apical hypertrophy, you could have minimal hypertrophy, even borderline hypertrophy with sarcomeric HCM. So even those LVH cutoffs may not apply to many patients with apical hypertrophy. And then, the second parameter I use is genotyping. And as you said, about half of patients with HCM has a true pathogenic sarcomeric gene mutation. So that may not define a patient with HCM either. And then you get a really thorough family history, and some of the patients may not know about their family history. So that also might be challenging. And I think one of the other most important things that we have to pay attention to is the longitudinal follow-up. So you actually have to follow up these patients. And if they have, for example, hypertensive heart disease, some of the LVH is going to regress over time. And you just have to make an effort, treat the hypertension and follow up with the LVH. But again, about a third of patients with HCM has concomitant hypertension. So there's going to be a significant overlap. So in most instances, it's rarely pure genotypic sarcomeric HCM. We're typically dealing with some other phenocopic mimic that we have to figure out as well. But this is really important. I'm so glad that you brought this up. We really have to make a diligent workup for these patients so we can identify those who are going to benefit from the novel therapies. So great talk again.
Thanks so much, Dr. Bowen.
Yeah, great talk, Matthew. I'll just echo what Matthew said and what Özlem said. There's no one diagnostic test for hypertrophic cardiomyopathy, so you have to use all the clinical tools at your disposal, the clinical context, as we mentioned, EKG, cardiac MRI, echo, genetic testing. All these things can help you, and any one step in that, going through those tests could point out that this is not HCM, that this is a phenocopy, or this is amyloid or something else. And I'll give you a quick example. I was guilty recently of anchoring. I assume it was anchoring. I'm maybe a different kind of bias. Matthew, you can help me. A gentleman moved to Atlanta from the West Coast, where he's followed at a very prestigious institution there and had been diagnosed years previously with apical variant HCM, and he was progressing towards end stages. And he had a device, so we didn't do an MRI, and he'd had genetic testing there that was negative, blah, blah, blah. Ultimately, I referred him on to my heart failure colleagues, and I'll give credit to my colleague, Dr. Sutaria, who actually said, maybe let's just make sure this guy doesn't have amyloid. And sure enough, he had amyloid. But, it come to see me as, sort of advertised as apical HCM progressing to end stage, and, and sometimes also just having a fresh set of eyes look at a patient can help as well. So no questions, just congrats on a good talk and those comments.
Thanks so much, Dr. Williams.
All right, if I can weigh in. First of all, I'll say that was a great talk. I might have missed this, but did the pathology come back on this paraganglioma yet?
Yeah, it did. So actually it was, they had done a biopsy of it, which beforehand, so I kind of did the case in reverse order. The patient actually had come to us with a known paraganglioma.
Yeah.
And it was biopsy confirmed, which I thought was very interesting that they biopsied it.
Yeah.
But yes.
But presumably it was obviously a secretory thing. I mean,
It definitely was, yes.
First of all, you have very good imaging. I think you should try to publish this. At the very least, you should send this to JACC Case Reports. They'll take it. But this is a very rare thing to see a typical HCM sort of pattern on imaging and see this. So I think you put this together very nicely. I think you should take it the next step and write it up.
I think we did that, Mike. I think this case is going to ACC.
Okay. Yeah, you guys should definitely do that. Now I'm gonna throw a Clayton Kershaw curveball in here with the genetic stuff. So first of all, what I would say, I'd flip the way you approach the genetic stuff and say, if you saw this imaging pattern and you sent genetic testing, which I'll come back to that in a minute, virtually everybody with HCM should get genetic testing, and you see a typical sarcomere variant, one of the 8 classic sarcomere genes, that makes your diagnosis virtually 100% in that case. So that is where the genetic testing helps you. But as you pointed out, not all of these cases are genotype positive, and actually the real world percentage is lower than what you quoted. If you look at burden testing results where they just use the guideline-based definition of LV hypertrophy, and they try to rule out people that have known significant hypertension, the chances of getting a positive genetic testing result is going to be somewhere between 30 to 40%. And that's based on worldwide data around different patient populations. But what we also know about HCM that has come out in the last 4 years is that there is a humongous polygenic component to this. I talked a bit about this when I did grand rounds a couple years ago. Actually, it was only a little over a year ago, which should be on the YouTube channel if people want to look at it. But there was a report in Nature Genetics that showed very nicely that this polygenic risk score that they created was very strongly predictive of developing quote unquote hypertrophic cardiomyopathy in people who were sarcomere gene negative and who had systolic and particularly diastolic hypertension. So it very strongly suggests that this polygenic risk background will predispose people to developing hypertrophic cardiomyopathy, i.e. it is a more robust hypertrophic response than someone without that high polygenic risk would get in response to hypertension. So whether we call that HCM or not, I don't know. The literature is still uncertain about what to do about this, but I would say from a clinical perspective, this is coming rapidly down the pipeline, and I think by the end of this decade, we're going to be doing polygenic risk in patients with HCM. There was actually just a new report published in Nature Genetics this month from the same group looking at a more refined HCM polygenic risk score, and they showed very nicely that if you apply a polygenic risk score, whether or not you've got sarcomere gene mutation positive or negative, you are it very much predicts both events. It predicts penetrance in people that have mutations. So there's a lot more to the genetic story with HCM. And in the long run, whether or not we call gene variant negative HCM or not is debatable. With the way genetics has progressed over the last several years, it's unlikely that we're going to find another MYH7 that accounts for 20% of all cases, right? We've sequenced hundreds of thousands of human genomes at this point. We would have discovered that. So yes, there are going to be a few rare genes that do cause HCM in extremely rare circumstances, but clinically those aren't going to be terribly helpful because it's going to be very hard to prove that those are actually causal. So this burden of sarcomere gene mutation or gene mutation positive is probably not going to ever exceed about 40%. So what we do with that other 60% is something that's going to evolve over the next 5 to 10 years. So is it still HCM? By the guidelines right now, yes, but we know that those patients behave differently. Their outcomes are not as bad, but it does highlight that hypertension has got to be the first thing you think about and look at whenever you're seeing this. Great talk, though.
Thanks so much.
For anyone that's scared about the boards, I'll just throw out there for the phenocopies, I really think on an adult board exam, you're going to see something about Fabry and PRKAG2. Those are the ones that, while very rare, tend to present more in adults. Almost all of the other ones you mentioned are more likely to present in kids with syndromic features or in adolescents in the case of Danon. And actually Danon more often than not presents more with reduced ejection fraction, HCM.
Thank you so much, Dr. Burke.
I guess I can throw out one more there about the genetic testing. So I'm on the guideline for HCM and the guideline committee for HCM, and I advocated that we should just give a blanket rec for genetic testing. And I actually got shot down based on my own example. But when I had clinic previously, I only ever had one HCM patient who did not have someone in their family that could be benefited. It was like a 60-year-old guy who had had a vasectomy. His wife was in her 60s. He had an adopted daughter. His brother had no children and was deceased, and he had no other extended family whatsoever. There was literally no one else to screen or test. But when you see HCM, just think about getting genetic testing. And just to remind everybody, we now do have a genetics counseling clinic. If you are in the ambulatory referral section, it's the cardiology genetics tab. Please, please send them our way. We can take care of the testing and the counseling and all that stuff for you.
Hey, it's Peter Block. Can I make a comment?
Yes, please.
I apologize. I missed the first 10 minutes of the talk because I was delayed, but I come at this from a practical point of view with aortic stenosis, of course, where you have intraventricular hypertension and so forth. We frequently see, I should say saw for me, ventricles that for all intents and purposes looked everything like HCM with obliteration and the usual chi-chi that you see clinically. Has anyone ever, one of the things we should do, I guess, in patients that have that, and they're not that uncommon when they come in with bad aortic stenosis. Does anyone know what happens to them long-term? I mean, I know there have been some short-term fibrotic studies of the ventricle and so forth. A recent one's coming out in JACC this week, actually. But the whole question really is, what's the best thing to do with somebody that has an obliterative ventricle in AS but doesn't seem to have anything else and no disproportionate upper septal thickening and all the other chi-chi that you like to see with HCM? Does anyone know anything about resolution of that over time if you put a TAVR in?
Matthew, I can take this one.
Please.
This is we've had, this is Robbie, Peter.
Hey, Robbie.
You know, we've had a number of these folks, right, who we've been concerned pre. Yeah, and I know you remember that we had a few that didn't go great because the patient, you know, the suicide ventricle thing is like sort of one of the dreaded complications of a patient.
Exactly.
Aortic valve replacement.
Exactly.
So if the patient has some degree of LVOT obstruction and you suddenly offload their ventricle with TAVR or surgical aortic valve replacement, they can develop extreme left ventricular outflow tract obstruction acutely, which can be you know, a very, very difficult situation to pull the patient out of. So we've had a lot of patients we've, you know, suspected whether it was a little bit of LVOT obstruction that was present before, a little bit of mitral SAM or small hyperdynamic ventricles, and done sort of pre-operative or pre-TAVR septal reduction therapy. I can tell you that it generally, I mean, you know, my experience with, you know, a handful of these patients, if you get them through the short term, the small hyperdynamic and the obstruction almost always goes away over time. Like I don't, you know, unless someone has like true significant HCM, but if they have sort of AS induced hypertrophy and that sort of thing, that in my experience, I haven't seen any studies, that in my experience almost always goes away after a few months, after, you know, after you replace their valve.
When you say go away, Robbie, what does that really mean? Does that just mean that their ejection fraction decreases? Does it mean that their ED goes down a little bit and then they get better?
Yeah,
you know, I think the question really is, shouldn't we get one of the fellows to look at this? We see so many TAVRs.
Agreed. It'd probably be a good thing, particularly these folks we had some degree at the begin, you know, pre-testing. I think it's just, you know, it's probably a number of things. It's, you know, LVH improves. You know, I don't know if you get sort of some reverse remodeling of the ventricle enlargement of LV size as a result, that sort of thing. You know,
I would hope that would be the case. And, you know, we all remember cases where they seem to be better, but we've never really gone back and looked at echoes and done some scans and so forth to see what really that looks like after a year, for example. It would be.
I just remember a number of patients I was sort of following for this sort of thing because they did have to get an alcohol septal ablation or something before TAVR. And It's like within a year or two, I can, you know, they don't need to see me anymore for their, you know, possible HCM or LVOT obstruction or whatever. It just sort of goes away.
Yeah.
Just
Okay.
on the
think-
subject. Oh, go ahead.
Sorry, I think we should take a closer look at this, Dr. Block. I agree. I mean, I have seen a couple of articles that looked into CMR regression of LVH post-TAVR, and they showed reduction in the LV mass and regression of the LVH and things like that. And I think it took some time, took about 6 months to 1 year. We do not have any internal data from Emory, which we should. I mean, we have a really large TAVR cohort. We have a very large HCM cohort as well. And there's quite a few patients with overlap of both.
Yeah.
So we can tell Matt, I know you've got lots of interest in research. This could be another opportunity for us to look into.
Yeah,
Absolutely.
okay.
Yeah,
Good.
this Shannon from Grady. I would also just add to that with the hypertrophy that we see in AS, like since 10 to 15% of patients referred to TAVR also have underlying amyloid. I'm curious in our group of patients getting TAVR what the prevalence of amyloid we're finding is, and then for patients who don't have regression of their hypertrophy after TAVR, just doing more diagnostics there and just looking at patients that we have and what data we have.
Sounds like an opportunity waiting to be grabbed.
Well, if there are no final comments or thoughts, we'll wrap it up here. Thank you again, Matthew, for a great presentation and everyone for a great discussion.
The preceding program is copyrighted by Emory University.